Hi and welcome back to the channel. We all know that the solid organ transplantation saves life, but immune compatibility challenges like donor specific antibodies and acute rejection can threaten the graft survival. TPE plays a vital role in both pre-transplant desensitization and post-transplant immunological complications. So today the topic of discussion is therapeutic plasma pheresis in solid organ transplantation. Why TPE in organ transplantation? So, TPE rapidly removes the donor specific antibodies, circulating alloantibodies, and immune complexes and complement proteins. It helps in overcoming ABO or HLA incompatibility, managing antibody mediated rejections, prevent and treatment of post transplantation complications. According to the ASFA guideline, in pre-transplant desensitization for ABO-incompatible transplant, HLA sensitized recipient, that is positive cross-match to high PRA, or living donor transplant with DSA positivity, the goal of the TP is to lower the antibody titers pre-surgery to allow the safe engraftment, which is usually combined with the rituximab IVIG immunosuppression, and the ASFA category 1 is given to this type of condition. How to approach a patient who is undergoing the solid organ transplantation? So, as a transfusion medicine specialist, it's a part of a transplantation team to prepare a SOP and circulate among the team members. Guidelines to be followed for like selection criteria, what is the procedure that need to be opted for this patient, and target titer level plus titration method. Then reviewing the patient clinical and lab parameters, perform additional testing like coagulation profile, TEG and calcium levels, written informed consent to be taken from the patient. How to determine the blood group and antibody titer. So donor and recipient, two persons will be there. So both blood typing should be done on two separate occasions and blood to be drawn on two separate occasions at different timing and submitted as separate sample and the results indicating the same blood type it should be there. A subgroup testing need to be done. There should be antibody titration method like IgG level by using DTT treatment, column agglutination technique is usually preferred. Then IgG measurement should be used to take the clinical decision and the target antibody titer is 8. Then vascular access like central or peripheral and the flow of the blood should be assessed. The normal flow is 50 ml per minute is preferred. And what is the choice of anticoagulant which will be used? For example, if there is a 50 kg patient with EBV of 70 ml per kg and SCT of 32%, the blood volume is 50 into 70, that is 3500 ml, and the plasma volume to be calculated as 1 minus SCT into total blood volume, which is 2380 ml. 1.3 plasma volume plasma pheresis need to be done, which is equal to 3094 ml, and the protein removed is the 3094 into 5.5 divided by 100, which is 170 gram, and replacement we are giving in the form of albumin, which is 128 gram in such patient. The use of TP in renal transplantation. So, if there is ABO incompatibility, then pre-transplant to lower the anti-A or anti-B titers, and if there is incompatibility post-transplant, then we have to maintain the low titers to allow the transplant accommodation. So, this is under the category 2. For HLA incompatibility pre-transplant, we have to permit the compatible cross-matching. So again it is category 2. For AMR, to remove the DSA to control rejection and protect and restore the organ function, it is category 1 according to the ASFA guidelines, and post-transplant AFSGS to control the proteinuria and preserve the renal function, it is under category 2. So apheresis alone does not ensure successful outcome. So other immunosuppressive interventions such as IVIG, antithymocyte globulins, splenectomy, rituximab, can be used in different combination in various protocols. Now, apheresis indication in heart transplant for the prophylaxis of rejection. The indication is the pre-transplant to decrease the donor-specific antigen titer, and the category is 3. In post-transplant to induce tolerance to the organ, it is classified under category 1. For treatment of rejection, acutely to remove the DSA and improve hemodynamics, it is category 3. And to induce tolerance to the transplant to decrease the recurrence of the rejection, it is category 2. So for the pre-transplant and acute cases, we will go with the therapeutic plasma exchange, or for the post-transplant, we can go with the extracorporeal photopheresis. For liver and lung transplant, in liver, for the desensitization of ABO-incompatibility in living donors, it is under 1 category, and for if you are going for the photopheresis, it is category 3. For the desensitization of ABO incompatibility in deceased donor or AMR condition, it is category 3 according to the TP, and if you are going for the ECP protocol, then again it is category 3. For lungs, for bronchiolitis obstructive syndrome, it is category 2 according to ECP protocol. Adsorbent recirculating system. So MARS, it's a dialysis-based liver support system which uses albumin dialysis to remove both water-soluble and albumin-bound toxin. It functions as bridge to transplant, or we can say bridge to recovery or bridge to decision type of system. So how it works? It is a combination of the three processes: hemodialysis, albumin dialysis, that means removes the protein-bound toxin like bilirubin, bile acid, cytotoxin, and ammonia. And third one is the adsorption with charcoal or ion exchange resin. So blood pass through the Mars filter, exchange toxins with the albumin dialysate, which is then cleaned and recirculated. So where we can use it, we can use this mass in acute liver failure, ACLF, refractive encephalopathy of liver, intractable pruritus in cholestatic diseases, hyperbilirubinemia, bridge to liver transplant. And we can see improvement in hepatic encephalopathy, hemodynamics of that patient, renal function, and neurological status. We have seen that in organ transplantation, plasma exchange is not used as a routine tool, but when the antibodies threaten graft survival, it can be a difference between rejection and rescue. So for more such videos, subscribe to the channel, and thank you.